Hi. Healthcare zombies. Bruce Barrett and Bob Evans first coined the term healthcare zombies in 1998. A healthcare zombies Healthcare zombies. Maurice Barry and Bob Evans first coined the term healthcare zombies in 1998. A healthcare zombies is a terrible idea about healthcare that refuses to die. No matter how many times you drive an evidence-based stake through its heart, it rises from the undead to confront you in the newspapers of the nation, ruining a perfectly good morning cup of coffee. These ideas have often been proposed as solutions to the pressures on our healthcare system, but they've all been shown, time and time again, to weaken healthcare quality and sustainability. They also undermine our shared values. User freeze a classic example. This zombie is restricted year after year as a suggestion to deter inappropriate care and raise money. The idea behind user fees is that if people are required to pay either a fee or a, co- a copayment, even a small one like $5 or $10 or percentage of the total cost co-insurance, they'll think twice before making an appointment for something silly. They'll thus curb unnecessary use and contribute some money out of pocket to help finance services as the skin in the game argument. As an abundance of evidence shows, this is a bad idea for persons or two reasons. First, user freeze at the point of the care indeed make patients think twice before seeking treatment. The problem is that these fees deter both unnecessary and necessary care. One US study looked at how employees reacted when their employees switched them from a full coverage plan to a high deductible plan, and which employee uh, had to pay a large sum of pocket before the insurance kicked in. The employees saved the money on the order of 15%, but the employees reduced the number of services they received to cut their own cost by much more, around 40%. They didn't shop around for better deals. Instead, all they did was to get less care, risking their health or the health of their loved ones to save money. This has been confirmed right here in Canada, in the birthplace of Medicare. In the late 1960s, the Saskatchewan government authorized physicians to charge patients $1.5 per clinic visit and $2 for outpatient services, including home emergency and hospital outpatient visits. The result was a drop in the use of those services, a drop most marked among people who could least afford to pay for healthcare and yet likely needed it most. Do we really want a woman to think twice before coming in for her PEP test, or a patient with chronic heart failure to put off her appointment with her cardiologist because she's already spent this month's income on other priorities? Do we want to burden parents with deciding whether their child's sudden stiff neck and cranky mood is due to a bad pillow or to meningitis, many meningitis, especially among lower income people. User fees reduce usage of the kind of health care we want people to get, and in most cases, seeking reassurance from the healthcare provider doesn't constitute abuse of the system. User fees are very blunt instruments for controlling usage. Beyond the human tragedies of these missed opportunities, care for advanced stage units is usually more expensive than the savings experienced by deterring preventive care. User fees are, as the saying goes, penny wise and pound foolish. Second, user fees are a bad idea because they don't actually raise much money. If you set a user fee low enough to be affordable for everyone, it has to be pretty low. By the time you pay the administrators who have to collect and account for the payment and co-insurance, you've created a costly bureaucracy that charges patients in order to support itself. In 2010, the government of Quebec made waves by suggesting a new approach by dealing approach to dealing with increasing healthcare costs. A fee of 25 charged to a patient for every visit to a physician, to be paid in a lump sum at the end of the year when tax time rolled around. Very low income people would not have to pay the fee. Careful analysis of the proposal showed that it would fail to produce significant revenues for government. In order to raise enough money to make them worth the bureaucratic effort, user fees need to be pretty high, and once you start setting fees at the level needed to really raise revenue, you begin to block access to those with low incomes with who may be quite sick. Alternatively, a significant part of the population would need to be exempted. So few people would be able to pay high fees that the policy would not generate considerable revenue. In the parade of the undead, close behind the user fee zombie, we can usually find the private paid zombie. The myth is that allowing wealthy patients to jump the queue will take pressure off the public system. I understand how this argument is intuitive. One might think that pulling one person out of the public queue would make the queue that much shorter, so that the private paid tire functions as a safety valve of sorts for the public system is not true. A study was conducted in Australia before and after that country moved from single-tire publicly funded care to two tiers, allowing privately funded care. It found that in those parts of the country that had more privately funded care, waits in the public system become longer. We saw the same results here in Canada when Manitoba experimented briefly with parallel private funding for cataract surgery, only to return to fully public system when public wait lists got longer rather than shorter. Why is this the case? Because the doctors, nurses, and others providing care in a privately funded system have to come from somewhere. What people forget what people forget is that when a patient jumps the key, a physician does too. The physician isn't available to treat the next person in the public queue because she's busy treating the patient who just paid privately to jump that key. Because she's busy treating the patient who just paid privately to jump that key. The drain on the public system by providers exiting to the privately funded sector created longer waiting lists in public health care. In theory, you could train enough doctor staff both. But the healthcare system isn't just made up of doctors. You need nurses, nurse practitioners, physicians, a physiotherapist, technologists, and an alphabet soup of other healthcare professionals. You need qualified administrators. You need the healthcare professionals. You need qualified administrators. You need a regulatory system to ensure quality and inspectors and accreditors to monitor it. Imagine the cost and time required to train people and build a private tower in a way that wouldn't siphon resources from the public tower, and in practice, privately funded tower even even provides an incentive to make wait times in the public system longer. A collective once told me that in New Zealand, surgeons talk about farming in their practices, tilling the soil by keeping their public wait times long and then harvesting the benefits of high-paying patients in their private practices. In 2006, the Canadian Medical Association reviewed all the evidence about two-tier and single-tier systems. Its report concluded that private health insurance does not improve access to services in the public system. It also concluded that private insurance does not lower costs or improve quality in the public system. In other words, access may improve for the small minority who can afford to pay, but patients in the public system can't expect anything good to happen for them if some people exit in a private tire. So private funding won't reduce wait times for everyone, or help improve quality in other public systems. Next in line comes the zombie of for-profit delivery. Clinic or hospital or facility might be owned by a group of investors rather than a couple of doctors, and those facilities have an obligation to bring profit back to their shareholders. Does it matter who delivers the service if the patient isn't being asked to pay out of pocket for it? Some argue that as long as patients use their health cards to pay for the service, it shouldn't matter whether those services are delivered by profit, by for-profit, more often called private clinics. It doesn't matter. As we move more services out of hospital and into the community, the number of private clinics inside the public system is growing. The, there are they are ardent supporters of such clinics who believe that because they are driven by profit, they'll be more efficient in the service delivery models. But if we are if we are to embrace for-profit hospitals and clinics in Canada, quality of care has to be at least as good as it is in the not-for-profit hospitals and clinics, and so far that doesn't seem to be the case. Instead, evidence on for-profit hospital clinics and long-term care facilities suggests that the care provided in them is inferior. In the United States, being admitted to a for-profit hospital instead of a not-for-profit hospital is associated with a statistically with a stati with a with a statistically significant higher risk for dying, having diagnosed in a for-profit instead of a not-for-profit facility is not associated with an increased risk of death, even if the care is still publicity funded. The evidence here in Canada points in the same direction. For example, in 2015, study looked at the rate of hospitalization and death among 50,000 people newly admitted into Ontario long-term care homes, also known as nursing homes. 6 months following administration, patients in for-profit homes were 16% more likely to have died and almost 36% more likely to have been hospitalized than those in not-for-profit homes. Even if we figure out a way to regulate quality in for-profit facilities, the business models out of the for-profit sector often involve upselling services and products that patients have to pay for. I think of my husband's friends who needs a colonoscopy, a service that was medically necessary and covered by OHIP. He was referred by his family doctor to a specialist who had hospital privileges but also worked in an out of hospital for profit clinic. He was quoted a price and advised that he could jump the hospital key and have the noscopy done in a private clinic a number of months earlier. It wasn't urgent, so he chose to wait for an opening in the hospital. He was subsequently contacted by the specialist office and offered an appointment for the colonoscopy in the private clinics. But when he raised the question of fees, he was told that the procedure would be covered by OHIB. When he arrived, he was seen by a dietitian who counseled him on the importance of a high fiber diet for his bowel health. He then had a procedure on his way out of the door. Sedated, he was handed a bill for $300, the cost of the non-insured dietitian consultation that he'd never requested, from orthopedic surgery centers to colonoscopy clinics to boutique primary care offices. Too many of these clinics find some way of charge patients for something. The core service is covered by taxpayers, but people leave having been unsold. Whether it's a fancy lens when they get their cataract removed, or some sort of assessment that only marginally related to the issue at hand, and in many cases they aren't closely offered the option not to pay for those extras, meaning that the for-profit delivery model ends up leading to compulsory private payment. Some remain unconvinced by claims that for-profit delivery can be incorporated into the Canadian healthcare system in ways that will help us achieve the triple aim of better health and a better patient experience at lower cost. Maybe it's possible, but I haven't yet seen the proof. So the zombies often use the fees private pay and not for-profit clinics all coverage in one of the worst problems of them all. To look at Europe argument, European nations have models of healthcare that incorporate some aspects of private payment and for-profit medicine. Say the supporters of their argument. Of course, we don't want American style health cares they concede, but why are we so afraid of following the European model? There's not such a thing as European model of healthcare. Such each country European has its own set of health and social services that have evolved in a very particular cultural, historical, and economic context. Most European nations invest more public money in their healthcare system than we do, but they also tend to have much broader coverage and more generous social safety nets, but the higher rates to support them. Proponents of the so-called European model don't seem to argue for European tax rates or European childcare policies. They pick they pick the one thing they like about the French or the German or the Italian system and talk only about a specific policy as if it uh, ex- existed in isolation, but we can't import French user fees and claim to have French health systems any more than you can throw a Big Mac patty into your baguette in your bagel and call it French cuisine. In French, having private insurance does not let you jump the key. It's voluntarily and use the primary to cover the co-payments charged in the public system, and owning the concerns about fairness, regulations, and increasingly aimed at preventing physicians from charging more money privately than they do publicly. In Germany, only 10% of the population has privately health insurance, and those who do must leave the publicly funded system entirely. I think it's unlikely that Canadians would be interested in such a model. Another important consideration when comparing Canada and Europe is the border we share with the United States. Canadian doctors earn more money than doctors in many European countries, and one of the market forces that drive the price of physician labor in Canada is the fact that we are in competition with the United States for our healthcare workplace. It's something that France, for example, does not really have to contend with. They share border as another important if in fact our trade agreement with the United States, including NAFTA, contain clauses that preserve the ability of Canadian governments to maintain single-tier Medicaid by regulating private investment in the healthcare sector, including by American firms. But if we were to move to private payment and for profit delivery, medical would no longer have those protections. We can switch to European style healthcare and not end up with American healthcare corporations surging into our system to claim that we could as to fundamentally misunderstood our political, economic, and geographic reality. Re- The suggestion that a magical European model will solve all our problems usually stems from a desire to allow some people to pay privately to jump the key, and some doctors to charge more for their services. Is nearly always made with a dogmatic belief in the free market, despite all the evidence of the inefficiency in the healthcare sector. That is said, it's always worth learning how other countries organize their services so that we might improve care in our own. In many European countries, for example, home and community care are much better integrated with other health and social services. We can certainly take the best of those care delivery models and adapt them for the Canadian context. When I asked my mother to write down her patients, write down her parents' story for me to include in this book, she finished her message with a reference to the Canadian and to Canada Health Act we chose when Monique the Breaking and the federal government of the day passed the Canada Act and Canada Health Act in 1984. She wrote it was far too late for our family, but it signaled the dawn of new hopes for all Canadians. Many Canadians who remember life before many can still feel this way, but in the context of an aging population, new technologies, increasing utilization of the services of questionable value, and concerns about system stability, medical care needs new approaches. Having dispensed with the zombies, let's explore these new approaches in this book with gratitude to the innovators who think about how to improve our system. I'm putting together the six big ideas I believe can best improve the health of care. Greetings, they aren't my ideas, but they are well formulated. They are grounded in good evidence and they meet in a two tests for delivery on the promise of Medicare. They would improve the triple aim of our healthcare system, delivering accessible, high quality services and in an actable way. And they are words of an iconic program. These big ideas would help us get better, much better now. And each idea is dedicated to a particular Canadian patient because it's important to remember who we are in this for. So next chapter we'll talk about big idea one and the return to relationships. And I'll see you tomorrow. Thank you.